later. We now will continue with the last speaker of this session, and this is Harith Alam, working in the Brompton and also in the St. Guy's and St. Thomas Hospital, expert in imaging, both echo and MRI and CT. And today he will discuss the technology imaging opportunities, and I'm very much looking forward. So the floor is yours.
Thank you very much. I'll just share my slide. Okay, can you see the slide now in full screen? Yep. Brilliant. Okay, so thank you very much for the invitation. And I'd like to thank Professor Gatsoulis in particular for asking me to give this talk. Now, I'm not anywhere near as qualified as the previous speakers, and I'm very grateful to them for having delineated in much more detail what actually technology can offer in practical terms currently. And this is mainly an area of research, but I want to look at it as from a perspective of a clinician, largely a clinician, rather than somebody who's actively doing research in this field, as to really what can technology offer now and in the near and in the distant future. Conflicts of interest, sadly, I have no shares in any of the technology that I'm going to be sharing with you. And as I've said already, I'm no technology expert. And really, you know, people are now holding conferences over several days on this topic. I attended, in preparation for this talk, the inaugural BCS, the British Cardiac Society study day on social media and technology. And to try and put that all down into 15 minutes means that I'm only going to be able to give you a whistle-stop tour. So I apologize for that. But I'm grateful that there is overlap with other talks already given and to come. So in terms of the themes, I'd like to talk about the technology, of course, and what do I mean by technology, and we'll cover that shortly. I'd like to give you a perspective in terms of history, because we can learn lessons from history to help us manage the present and the future. And also to look in terms of society within cardiovascular disease, what advances have been made and how that can be applied to CHD. And really, one of the things we need to learn is that technology both presents an opportunity for us to enhance the patient journey and civilization, but also a threat as well. And really, I want to sort of ground all this by focusing really on the patient's journey, and I'll try and ground it in a case that I was recently involved with. So let's talk about the tech first. I'm going to cover a few things. Some things have been covered in some detail already, so we can skip through some of that. But social media, I'm going to concentrate a lot on. Apps and monitors, and these are things that are really already available for us. IT systems and telemedicine, there's been a huge advance in that in the last 6 months because of the pandemic. And I think all of us have become more expert in this field than we were just 6 months ago. I think my previous speakers have already touched on big data and artificial intelligence and how that can analyze a raft of data. And then we'll probably finish with what is really the long-term goal, which is precision medicine, rather than what we used to call personalized medicine, and that's PHealth. So in terms of perspective, if we talk about society, we started off a few thousand years ago with the invention of the wheel. Now we have electric cars available to us. And very soon we will probably have hovercraft that can take us cheaply and quickly from one place to another, and hopefully safely too. Within the world of cardiovascular medicine, 100 years ago, the ECG that Eindhoven invented, and now we have, accessible these portable monitors. And my brother even bought me one of these watches that can record your ECG. I think many of us have this, and many of our patients now have this. So this is technology that's here already. Within congenital heart disease, we start off with surgery that was done in the late 40s, I think, on the Blaylock operation and shunt. And now we have advanced technology that allows us to combine imaging and fluoroscopy to manage complex interventions on patients to minimize the invasive treatment that they have and improve their patient journey. The question really is, this talk is, what is this technology going to do for the future of CHD? So again, just to some philosophical considerations, we have made huge advances in terms of science, in terms of pushing the boundaries by colliding protons together in that Large Hadron Collider in the ATLAS project. We've discovered the Higgs boson that was predicted about 50 years ago. And then on a huge sort of universal cosmological scale, Einstein predicted that black holes would cause gravitational waves, but he thought that we would never have the technology to be able to detect them. But that technology, through technological advancement, has now become available, and we can detect those waves, which is really fascinating. But I think that excitement has to be tempered with some reality and humility that we don't know everything and we can't control everything yet. And this little, if we just go up one scale from the quantum world to the microscopic world, these small viruses are causing chaos within our advanced technological societies, as we see. And this is the latest graph at the moment of how the second wave is climbing in the UK. And then if we look also at the world scale, we haven't mastered global warming and climate change yet. And this is obviously, these are huge topical considerations. Don't take it from me, but take it from people who are experts in the field. So Christian Liu Lang was a Norwegian Nobel Prize internationalist, and he said that technology is a useful servant, but a dangerous master. But Steve Jobs was more positive. He thought that technology is nothing. What's important is that you have faith in people, and they're basically good and smart. And if you give them the tools, they'll do wonderful things with them. And that's really a hopeful message. Sadly, he's also passed away, as has Stephen Hawking, who was actually a bit more negative and said that there is a very real danger that we will kill everything on this planet now that we have the technological power to do so. But I think that all this speaks to really the human interaction with technology, which determines which direction we're going in. Now I want to take you, ground you down back into a patient. So I started at the Brompton a couple of years ago, and I took over an advanced or end-stage heart failure clinic. And this was a patient that I took over sort of quite late in his journey, but he was only in his mid-30s. And he, you know, this is a story that I'm sure many of you are familiar with. Somebody born with complex congenital heart disease, initially palliated with a shunt, requiring medicine. Unfortunately, comorbidities are common in our patients, and he developed type 1 diabetes, which didn't go well with his needle phobia, and he developed kidney disease. He developed liver disease, as has already been touched on in Fontan. And when he got to the stage of transplant assessment, because he was having recurrent heart failure admissions for almost a decade, unfortunately, his diabetic control and his kidney disease and his liver disease made him not an attractive candidate, and he missed the boat for transplant. And then for the last 2 years, I've been looking after him in his end stages with long hospitalizations. But amazingly, through the help of technology, for the last year, we managed to keep him out of hospital. And, you know, even to the point in the pandemic that he was actually serving his parents food and shopping, and able to do that until just a few weeks before he finally succumbed to his illness. The question is, can technology improve his patient journey? So I just want to take that patient and look at the journey that actually all of us have and all our patients have. We all start off as a twinkle in the eye of our parents, and then we're conceived, born, and then many of our congenital patients will undergo interventions at that stage. Then they go through childhood and transition. Hopefully they go through a healthy and productive adulthood, as my patient did, before they start developing symptoms and need treatment, advanced disease, and then end-of-life care. So, you know, there are domains that we need to think about when we're thinking how technology can apply. There's the personal domain of the patient, his or her lifestyle, what they enjoy. There's their circles of influence, family, friends, and societies. There's their interaction with society in terms of work and education. And finally, there's the healthcare. And we should remember that healthcare is only one part of the patient's perspective. And the question of this talk is, how can technology help to enhance the patient journey? So without further ado, I'm going to go through the technology now. So social media, first of all, I'm going to spend most of my time on this, which hasn't been covered as much in the previous talks. So this is social media in the past, and you can look at this slide and look at the pictures and see where you are at in terms of your social media. I think I personally am still very much at the email and text message, or maybe now I can say WhatsApp stage of communication. I'm still a little bit of a dinosaur when it comes to technology. But you know, have a look at that and see what you think applies to you. This is supposedly the past. This is the present of social media, and there are a wealth of apps, and these are the most sort of popular apps in the last few years. I have an idiot's guide for the apps if you're not sure, and somebody used the analogy of donuts, which I understood. So, you know, Twitter is about I'm eating a donut and the sort of immediate action. Facebook tells you about your likes and dislikes. Foursquare is where you are. Instagram is a photo of it. YouTube, a video of what you're doing. LinkedIn is about your skills in donut eating. Pinterest is a recipe for how to make donuts. And then there's others as well. If you want a shortcut for which social media app is best for you, then use this as a guide. If you've got all of these characteristics, then maybe Twitter is the best for you and most versatile. So I'm going to go through these apps in a little bit more detail and see how they could apply in medicine and in our patients. So Facebook, first of all, I think this has a huge utility for patients in particular, because it provides them with a support and advice network, starting with family, distant relatives, friends, groups such as patient groups for different conditions and societies, as well as healthcare organizations such as charities and trusts and services. Now, Twitter is by far probably the most popular social media technology. Apparently, almost a third of the world is now using it on a monthly basis. And this is just my own, just in preparation for this talk, I sort of signed up to Twitter, to Facebook, sorry, and you can see that I don't really check my messages, but you can look at lifestyle Facebook pages to encourage you to have a healthier lifestyle, charities that help you to manage your disease better, and even as a care provider, somebody with an interest in imaging, you can get very rapid updates on your phone from people around the world, educational updates and interesting videos and cine loops of echoes to share and to comment on. Now, Twitter, I think this has huge versatility and a role, particularly for clinicians and healthcare providers, but also potentially for rapid dissemination of information to patients as well. So as you probably know, that Twitter is a microblogging tool, and it has a limit in terms of how much you can do, and that makes it really concise and easy to digest. You're allowed 280 characters, 4 pictures or 2-minute videos. It's an open, easy platform to use, and you follow people with a hashtag. And really, it's probably the most widely day-to-day used social media app. And now currently estimates are 150 million users use it. So this really, has evolved hugely. You can have Twitter feeds to follow, like in this ESC Congress. And this is somebody displaying what digoxin must feel like after the RATE AF study was recently produced, sort of swaggering down the road, having had a revival. You've got the latest guidelines in non-STEMI, which you can digest in one abstract to your phone. And then you can really progress yourself from a Twitter virgin to a Twitter scholar. And there are even prizes for people who do the best procedure, such as left distal radial access, which is really caught on like wildfire, much quicker than you would have had before the era of Twitter. You can have tutorials, and then you've got the Twitterati, and these are the top 10 a couple of years ago of the UK Twitter users. Instagram, as I said, is picture-based, and for people who think a picture says 1,000 words, then this is very useful. Some people like to listen as they're going to work, and again, this could be good for patients to learn about their condition, about healthier lifestyle, and for clinicians learning about advances and about diseases. And YouTube is a video-based. I use this for fixing things. How do I fix my bike? How do I do this? And I think you can learn a lot, in tutorials and lectures, and it has a huge following. So some challenges and rules with regards to social media. It's not peer reviewed, and it can take over your life. So you have to strike a balance. Patient confidentiality is at risk if you're sharing patient health data, and consent is important in this. Be careful not to post in anger, and be wary of trolls. So, I think the rules are not to fear it, but be respectful. And strive for accuracy, and try not to ask the patient's permission, and do not put any specific patient advice in there, because that has medical legal implications. So in ACHD, I think this is really exciting that it's really taking off. Within the UK, you have the Somerville Foundation, an ACHD charity, who invited me to talk on this subject a couple of years ago. You have in the 2020 ESC guidelines published last month, the ACHD guidelines. It's interesting that in a survey of UK cardiologists, ACHD seems to be behind intervention and imaging at the moment in the uptake of social media, particularly of Twitter. But I think this will change, hopefully, in the next few years. You've got now vodcasts, such as the Heart University, which is an excellent free access site based in the States, but with worldwide participation. And that's talking about the guidelines. And just a little plug for what we're doing locally in terms of a webinar on imaging in ACHD and PH, which is coming soon. So how can social media enhance the patient journey? Well, I think it's got a huge role in terms of for patients and doctors in communication, providing feedback and peer support, and it can allow rapid dissemination of knowledge and collaboration in terms of clinical and research, and enhance RCPD. Monitors and apps, this is what was available for the last probably 2 decades or more. The problem was that we didn't have a way of keeping all this data together, and also keeping ourselves up to date with how to use the data, because it was very time consuming and laborious. Now I think we have more monitors, such as INR monitors, we have ECG monitors, and now we have the apps available on devices close to the patient, which can integrate all this data. And there's some evidence growing now that people who are monitoring themselves do better in terms of blood pressure control, in terms of INR control, in terms of AF diagnosis and outcomes as well. What is the future in terms of apps and monitoring? Well, this is almost a reality now. People are trialing monitors which can give you a wealth of data and can integrate with your mobile device, and then can link through that and a server to healthcare providers, research organizations, patient portals. And I'm particularly intrigued for patients with advanced congenital heart disease, that perhaps for those patients who are at risk of sudden cardiac death, but not enough to need an ICD, whether wearable technology will allow the day where we can predict those who are at risk, and we can do some intervention such as AED with accessibility to it to help them. The challenges with mHealth is the lack of evidence. The technology is growing far quicker than the regulation can cope with it. It does generate anxiety, and this is a big question on how we're going to deal with that. Mental health is significantly affected at the moment in anyway. And data security, as with all of technology, is a major issue, and there can be conflicts of interest. So in ADHD, this is a burgeoning field as well. So I'm grateful to people within the UK who have developed these apps. So we have something that can give you your personal heart picture. You have the Bristol group that have developed a My Heart app, which gives you a personalized information and repository. A patient who came to me at the talk I gave 2 years ago said that she was developing an app to include all the relevant data. And I think this is now translating, is about to go into real time, the Heart Hub app. And then even at our trust level, we're developing apps which allow patients to ask their clinicians questions in advance of their clinic appointments. And just next week, I think at the Brompton, they're going to introduce this app, which will allow patients to keep hold of information and upload monitoring information on a weekly basis. So I think mHealth can really contribute massively to the patient journey, particularly with allowing data from the patient to be accessible to healthcare providers and to the patient as well, to empower them. And it will enhance communication. And I think it could lead to better outcomes. IT and telemedicine, if you look at this and what is supposedly the past, there are many hospitals that are still using this technology for storing patient records and for transferring data. And I think that's a real stumbling block and a restrictive point in technology. I think we've made huge progress in the last 6 months. In terms of telemedicine, we've learned a lot from Formula One and from space aeronautics. I think this video, if I just may play it for a minute, just shows you our experience of using Teams.
Tyler has joined the meeting. All right, well, this is Trip. Who's here? Tyler's here. That's here. Okay, the purpose of today's meeting is to discuss the...
Yeah, I'll be able to do it in like 30 minutes. John
has joined the meeting. Hi, John. Hi. I was just trying to go over the purpose of today's meeting, which is to discuss the deliverable. Tyler has joined the meeting.
Sorry, guys, I got cut off. Is Paul here? Send him an invite.
Put in your access code.
No, that's your...
In the interest of time, I'm going to move on, but you can find that video. It's hilarious. So I think integrating that, I think IT has traditionally been a stumbling block, and I think that's because we don't work closely together enough with IT, which live in a different area to us within healthcare systems. But the last 6 months has forced us to work together, and we've made great progress in terms of integrating IT systems and out of clinical need. And I think that needs to continue, that collaboration, and not just within one institution, but between institutions, between regions, so that really the data that patients then provide can be accessed whenever it's needed to the person who's looking after them. And I'm a bit of a lazy person, so this is my dream state where I can do everything sitting in my chair and manage my patient remotely. The challenges of that is that, all this interconnectedness does make us more vulnerable. And I'm all too aware of this WannaCry virus when it came out. It was my first on call at St. Thomas's Hospital, and all the surrounding hospitals were closed, and there were 5 times more admissions and primary PCI admissions over that weekend. And I was direct, had a direct impact on me. So the other downsides of telemedicine is that you don't get that direct contact with the patient, which some patients need. So it has to be tailored, I think, to patient requirement. But there's no doubt it could potentially reduce the burden on healthcare. So how can telemedicine affect the patient journey? Well, I think we've already in the era of virtual MDTs and consultations. It will allow better data sharing, and it can be cheap and remote with the technology that's already available. In the future, perhaps it can allow robotic interventions and delivery of healthcare and treatments to patients who live more remotely. I'm going to skip over a lot of big data and AI, as I know that Professor Diller is going to talk about this. But what is big data, and what does it mean? One of the gurus in big data suggested that big data is like teenage sex. Everybody's talking about it. Nobody really knows how to do it. Everyone thinks everyone else is doing it, so everyone claims they are doing it. Well, basically what it isn't is what we traditionally think of as data: audits, cohort studies, registries, and trials. There is a lot of waste in that because by their nature, they're very controlled studies, and a lot of the data is lost in that process of analysis. What big data hopes to do is to integrate all of the data, and it has to have 5 V's to be fulfilled for it to be accurate. And that is, it has to be fast data, it has to be overwhelming volume, there has to be a variety of data, things that you don't even think are important potentially. It needs to be lacking in errors of omission. This is probably the Achilles heel of such data, and it has to have value and clinical utility. The main skepticism about big data and artificial intelligence analysis is that the data gets plugged into a black box and you come out with a prediction. And some people are still skeptical about how that works and does that actually translate into clinical benefit. But this is happening, as the previous speakers have shown, that you can put together all this data source and you can analyze it through statistical methods or machine learning, and you can come up with outcomes. This is happening on a huge scale. So the UK Biobank studied 500,000 people in the UK, and 100,000 of those were imaged with MRI. And intriguing things have been learned. For example, with that big data, they've been able to learn that pollution actually is associated with enlarged left and right ventricular end diastolic volumes, something we would never have been able to do without this methodology. There are huge challenges with big data and salutary lessons, such as data breaches that happened a few years ago within London that led to a large fine from the Office Commissioner. Again, it's all about data security. So I think in terms of big data, AI, and the patient journey, it can allow its reproducibility makes it very strong for research. It can potentially help us with our clinical decision making in the future. And finally, precision medicine, which is the culmination of all the things we've spoken about. It's moving away from the traditional medicine where we put everybody into one group and give them a therapy that works for only some of those patients and potentially harms others. We're in the era now where we're stratifying patients more, such as after infarction, into what therapies they're given according to their risks. But really what we want to move to is individualized medicine or precision medicine, where we use biomarkers together with other features to sort of give individual treatment to patients with less waste. And we've done this traditionally in cardiology. When somebody comes in with a heart attack, we would look at their ECG, their X-ray, their angiographic findings, their hemodynamic status, to risk stratify them and work out how to manage them. The intriguing question is, what can genomics and DNA do to interface with that knowledge and enhance that knowledge? Now, the Human Genome Project took 13 years and cost $2.3 billion. Now the technology allows you to do it within a few days at a cost of less than $1,000 with a simple laptop computer, which is remarkable, the staggering progress. And really now we can integrate much more data in somebody who's had a heart attack with imaging data, hemodynamic data, and we can combine it with genetic data. This is the titin protein, and it's intriguing that in some studies it's been found that titin may predict adverse outcomes after infarction, for example. In terms of adverse remodeling. And this is just a flavor of what potentially is possible. The future, well, I think you've all probably heard of the CRISPR protein, which may allow us to alter our DNA. That has huge ethical implications. But what I see is that there's a wealth of data that's going to be in mHealth, which is going to be combined with new technologies to give us really precision medicine. And epigenetics is also an important factor in that. The challenges are, again, with the data security. And the interconnectedness allows this to work, but it also provides a vulnerability. And this is a huge challenge for us. So within ACHD, if you just allow me one more minute, I would like to just show you that within our own center, we are trying to put PHealth into practice. So using non-contrast MRI with this new novel MTC boost sequence, we're able to make 3D models of the pulmonary valve in people with tetralogy fallow and predict who, with a native pulmonary valve, could potentially have a transcatheter pulmonary valve implantation. This is a patient of mine who presented with heart failure and atrial fibrillation, who had a huge aneurysm of the right coronary artery, which was fistulous to this coronary sinus, and we had to use 3D printing to determine that she wasn't suitable for interventional treatment and had to go for surgery, which she had successfully. And this is another example of the sinus venosus ASD. So I think PHealth is probably the final common pathway for this technological advancement, and it has huge potential to allow us to rationalize therapy, improve diagnostics, and risk prediction. So, putting it all together, there's a lot that we can do to enhance the patient journey. If we think back to our patient, perhaps, the little gains from each of these steps would have allowed him to perhaps not miss the boat with regards to transplantation or altered his prognostic pathway. So my take-home messages are that technology itself is neutral, but has huge potential benefits. It can be costly and harmful. So really, it's upon us as the people who are using the technology to make it patient-centered in its approach. And really, we need to collaborate for it to work properly. I'd like to thank all the people who helped me to put these slides together and gave me some information, particularly the organizers as well, and Professor Gatsoulis. Thank you.
Thank you very much, Dr. Alam. This was a beautiful presentation and something of the current times, the current era, and I think lots of things can be done and learned, and it was a nice overview of a lot of information. Thank you very much.